Hi, Mia Green. Hello. The code to get in is 857-6446. Hi, Leonie. Kamaldeep. Hello. Hey, guys. Good evening. Oh, Leonie's joining from British Virgin Islands. It's so beautiful there. Nadine says, I finally catch a live. Yep, you finally caught a live. Good evening. Free Palestine says, good evening, OMG. It's my first time doing this live. Yup, you finally caught it. MKS says, what's the topic today? We're going over maternity, pharmacology. So we're going to go over like the most important drugs you need to know for OB, maternity. Yolande say, how do I join? Take your phone and you can just, that QR code, you can just do that QR code to get in or download the Kahoot app. Sheriff Season, you're amazing. I done promoted you to everyone in my nursing program. Thank you so much. I appreciate that. That is like, if you appreciate what I do, that's the best thing you can ever do for me. Refer me to other people. So many people don't know about me or my services, so I appreciate it. Tiara, hi, Professor D. I can't wait to hear you say, don't you ever in your life. Oh, I love you guys too. Queen Asta, yay, I have maternity and peds cumulative exam this week. See, right on time. Look at God. Look at God. That's what I'm talking about. I'm a kid. Can I join? Absolutely. Just make sure that you have your parents' permission. Mo, I haven't done maternity yet. I'll still answer. Yep, this is great practice. This is great practice. Yep, so we're going to be going over maternity. You know what? I should have poured me a glass of wine before I even started this. Oh, gosh. I guess. All right. Jazz says, I want to play. The code to get in is 857-6446. So will this be recorded, headed into mental test tomorrow? Yes, this is going to be recorded. After this Kahoot, I'm going to post it on the YouTube channel. Mo says, I love red dry wine. My husband does. I'm not too much of a fan, but my husband loves it. It's December, and in my culture, and I'm Haitian, we love to drink. It's called cremas. It's like I don't even. It's like a Bailey's. It's a Bailey's Haitian style, and I love to drink that. And I could go. You know what? Do me a favor, you guys. Go ahead in the comment section for the newcomers. Tell them I'll be right back. I went to go fix myself a drink. I'm gonna go fix myself a drink. I'll be right back. Put in the comment section for anyone that comes in and is asking for me. I'll be right back. Okay, I'm back. Okay, we're almost there. Once we hit 75 people in the room, we're going to get started. Patience, Jody. Four more people. We're at 71. Thank you, Tristan. Love you guys more. All right, we're at 75. We're going to get started. Now, before we start, please, for the latecomers, they're going to come in and ask the code. Can you guys just type in the code on the live? 857-6446. 857-6446. So when they come in, they don't even ask. They'll see it. Type in the live for me, please. 857-6446. Thank you so much. Maternity pharmacology. First question, select all that apply. Which instructions would you include in discharge teaching for a patient that received methotrexate for an ectopic pregnancy? Here are your options. Avoid sexual intercourse until HCG levels return to normal. Take folic acid supplements daily to promote healing. Avoid consuming alcohol while undergoing methotrexate therapy. Return for follow-up visits to monitor HCG levels. Avoid NSAIDs while on methotrexate. Avoid getting urine on the toilet seat and double flush with toilet lid down. Select all that apply. What are you going to teach this patient that is getting methotrexate after an ectopic pregnancy? Is this better, guys? Okay. Everything except for blue. So let's talk about what you're not going to teach them. Then I'll go over the correct answer. You are not going to tell them to take folic acid supplements daily. You tell women who are pregnant, who actually has that fetus growing and they want it to grow, you're going to tell them to go ahead and have folic acid. It helps with development and CNS. But this person just had an ectopic pregnancy. Methotrexate is the antagonist of folic acid. So why in the world would you tell them to take folic acid? That is wrong, okay? Everything else is right. You're going to tell them to avoid sexual intercourse until those HCG levels have gone down to normal. We don't want them to get pregnant during this time. They may have developed scar tissue. This patient has to be assessed. This is not the time to be getting pregnant. Of course, we're going to tell them to avoid consuming alcohol while they're on methotrexate. They shouldn't be drinking alcohol while they're on any medications. That's across the board. They need to avoid NSAIDs while on this medication. We don't want any bleeding issues. And we're going to have them keep coming in, returning, because we're going to be checking the HCG levels. We need to make sure it goes down to normal. And avoid getting urine on the toilet seat and double flush with the toilet lid down. That is absolutely true. This drug is so toxic. We don't want it to be aerosolized at all. Okay, I'm going to go more into detail about this drug, but that absolutely is one of the things you're going to teach the woman. Next question. True or false? Methotrexate is a hazardous drug and can cause serious toxic effects even at low doses. Is this true or is this false? I'm sorry, I accidentally gave you the answer. Sorry about that. Is this drug toxic? Even at low doses, true or false? All right, let me move it closer for you. Maybe that'll help. True. This drug is very, 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 let me tell you how, let me tell you how toxic this drug is. We take this drug very seriously. You have to be very careful. The pharmacist in the pharmacy is the one that has to prepare this drug and prepare that dosage, not the nurse. It's number one. When the pharmacist has that drug in the syringe has to be in a plastic bag. Needle cannot be in that bag. It's going to be separate. That's number two. When the nurse actually gives this medication, you know how you put on gloves when you're going to give an injection? Guess what? You have to put on 2 gloves. You got a double glove. Number 3. Am I on number 3, number 4? I don't remember. But something else you got to know about this drug. You know how you want to prime or expel air out of the syringe? You cannot with this drug. We cannot have this medication aerosolized at all. When you get rid, after you give this drug, you don't just put that syringe in, trash. It has to go in a hazardous wastebasket. Hazardous, okay? This drug can be very, very, very toxic. You have to be very careful. All right. Which statement from a patient taking methotrexate for rheumatoid arthritis requires further teaching? Is it, I should stop taking methotrexate at least 3 months before trying to conceive? Is it, I'll need to use a reliable form of birth control while I'm taking methotrexate? Is it, if I get pregnant, I'll continue to take it until my first prenatal visit? Or is it methotrexate can cause serious birth defects if taken during pregnancy? Which statement would require further teaching? Very good. Most of you guys got it correct. If she says, oh, if I get pregnant, I'll continue taking this drug until my first prenatal visit, you're going to have to do some teaching with this patient. This drug is a category X drug. It is teratogenic. You get pregnant while you're taking this drug and you continue taking that drug, you're going to mess around and have a fetus with 12 eyeballs, okay? It is very, very teratogenic. The fetus will have birth defects, okay? Everything else is correct. I should stop taking methotrexate at least 3 months before trying to conceive. Yes, we need to make sure that drug is completely out of your system before you even think about getting pregnant. I'll use a reliable form of birth control while I'm taking methotrexate. Yes, because we understand it's a category X drug. You cannot get pregnant while taking this drug. And you understand that it can cause serious birth defects if taken during pregnancy. Okay? Your patient's receiving magnesium sulfate for severe preeclampsia. Which finding would require immediate action? Would it be a respiratory rate of 10 breaths per minute? Would it be deep tendon reflexes of +2? Would it be a urine output of 40 milliliters per hour? Or would it be a blood pressure of 150/90? What do you guys think? If you guys are not in the Kahoot, you can still participate. Just type in your answer on the live. Okay, very good. Respiratory rate of 10 breaths per minute. So guys, what is the minimum that the respiratory rate should be? You guys on the live, tell me, what is the minimum? What number? Quickly. Thank you. 12. 12. Think about it. This drug, first of all, let me point something out to you guys. Whenever you guys get a test question and they give you a diagnosis and they give you a medication and they ask you what you're going to be concerned about, what you're going to do, the question is always about the medication. Don't get distracted by the diagnosis. So this question says your patient receiving magnesium sulfate for preeclampsia, your answer, what you're going to be concerned about, is not going to be associated with the preeclampsia. It's going to be associated with the magnesium. Think about it this way. If they mention a drug that you are about to give or that you just gave, it's a drug that's going to change something chemically in the patient's body, not the disease. They already have the disease, right? So you're concerned about that medication you're either about to give or you just gave. Questions like this are very misleading because a lot of students will see preeclampsia and they'll try to find an answer that has to do with preeclampsia. Forget that. That's not what we care about. We care about the drug. We care about magnesium sulfate. So when you see this question, you got to say to yourself, okay, what do I know about magnesium sulfate? Okay, well, I know magnesium sulfate will cause relaxation of the muscles, right? It can cause relaxation of the muscles. It can, relax things. Well, what happens if it works a little bit too well, right? Those respiratory muscles relax a little bit too well. Boom, decreased respiratory rate. Deep tendon reflexes of +2, that's normal. I'm not concerned about that. Urine output of 40 mLs per hour, that's normal. You should have at least 30 mLs per hour, right? So I'm not concerned about that. That blood pressure of 150/90, I'm happy only 8 people got tricked by that. I was hoping I'd get more of you. But yes, that is an elevated blood pressure. Yes, it's not normal, but it's not as deadly as that respiratory rate. Whenever you get a question that's asking about to prioritize, right? And you have 2 answers. Both of them are abnormal and you can't figure out which one to choose. Say to yourself, which one will kill my patient the fastest? Which one is the deadliest? 150/90, yeah, slightly increased, is not going to kill you, but respiratory rate of 10, don't even play. Can you live without breathing? Absolutely not. How are you guys doing on the live? Eris said, period, professor. All right, next question. If magnesium's toxicity is suspected, what should be your first nursing action? Are you going to call the healthcare provider? Are you going to administer the antidote, calcium gluconate or calcium chloride? Are you going to discontinue the magnesium? Are you going to increase the flow rate of magnesium? What are you going to do? If you suspect magnesium toxicity, what is your first action going to be? Very good. Most of you guys chose the correct answer, discontinue the magnesium, but I'm kind of concerned that 21 of you went with administering the antidote. So let me get this right, because I'm going to walk you through this. When you guys choose these kind of answers, I want you to see what you're telling the test writer. So for 21 of you that said you're going to give the antidote, what you're telling me, the test writer, is that you recognize this patient's getting way too much magnesium. You recognize that this magnesium is harming your patient, it's killing your patient. And while that poison is still infusing into your patient, you're giving them the antidote. What is that antidote going to do if it's still infusing into the patient? I'm telling you right now, whenever you get a test question about something that's harming your patient, every single day of the week, the first thing you are always going to do is stop the infusion. Whatever's harming your patient, you stop it first before you give an antidote, before you assess them, before you give them oxygen or fluids, before you do anything else. You stop what's harming your patient. Does that make sense? Are you guys with me? You picking up what I'm putting down? Okay. The screen is cut out. It looks like it's saying continue the magnesium. Oh, I'm sorry, guys. I don't know how to fix this for you. I'm sorry. Call the healthcare provider. 2 of you guys chose this. So let me talk to you about this. Before you're tempted to click on that answer choice of call the healthcare provider, look at your other options. Say to yourself, can I do any of these for my patient before I pick up to call the healthcare provider? Right? So you see that you suspect your patient's going through magnesium toxicity. Let's talk about this because you got to know what those signs and symptoms are. Your patient's, excuse me, your patient's getting magnesium. You better be watching out for decreased respirations, lethargy, confusion, slurred speech, decreased deep tendon reflexes, right? Those signs and symptoms of magnesium toxicity. If you note that, you don't need to call the healthcare provider to stop what's harming them, right? Look at the other option, administer the antidote. Guess what? If you have that as an option, the antidote, it's been ordered. What are you going to do? Call the healthcare provider and say, hey, this patient's going through magnesium toxicity. I know you ordered it because I have the order for the antidote right here, but I'm calling you just to double check. No, you're delaying care. You're letting your patient die. Absolutely not. And one person chose increase the flow rate of magnesium. Yeah, you're getting your license snatched, honey. I'm so sorry to tell you that. You see your patients going through magnesium toxicity, which means that they're getting a lethal dose, and your bright idea is to go ahead and increase the flow rate? Absolutely not. No. We want to keep our patient alive, right? We're going to, number one, stop that infusion. Number two, give the antidote, which is either calcium gluconate or calcium chloride. Number three, assess the patient, get vitals, so when you call the doctor to say what's going on, you actually have something to say. Does that make sense, guys? Why are you guys laughing at me on the live? All right, let's keep going. All right, what drug is a drug of choice to treat eclamptic seizures and prevent repeated seizures? Here are your options: hydralazine, labetalol, methyldopa, or magnesium sulfate. I'll repeat the question. Which drug is the drug of choice to treat eclamptic seizures and to prevent repeated seizures? Is it hydralazine, labetalol, methyldopa, or magnesium sulfate? Very good. Magnesium sulfate. Professor D, do I need to know that? Absolutely. I promise you're going to see that as a test question somewhere within your academic career. You need to know this, okay? When it comes to treating eclamptic seizures and preventing repeat seizures, it's magnesium sulfate. Let me tell you something. Lots of students, another question you very likely may get is, what is the purpose of giving magnesium sulfate? I'm telling you right now. I'll tell you what the purpose never is. To bring down the blood pressure. Why? Magnesium sulfate has so many adverse effects. We have lots of drugs on the market to bring down the blood pressure. The patient just happens to be hypertensive, and we need to bring down the blood pressure. We can give them hydralazine. Heck, we can give them labetalol as long as they don't have asthma. When it comes to labetalol, if the patient has asthma, they've got bronchitis, they've got emphysema, they have some type of respiratory condition, you're not going to give them labetalol. But other than that, you can give them labetalol. Methyldopa, that's to treat hypertension during pregnancy, right? There's so many drugs on the market that can bring down the blood pressure without the adverse effects. We will never give magnesium sulfate just to bring down the blood pressure. Magnesium sulfate, those are the big guns. We're giving magnesium sulfate to prevent eclampsia, the eclampsia seizures, or if the patient already had eclamptic seizures, we don't want it to happen again. That's when we give magnesium sulfate. You guys got to know the difference. I promise you'll get at least one test question on it. Okay? All right. I talked to you about everything I want to say about the screen. Let's move on. How are you guys doing on the live? What's the PIN? The PIN to get in is 857-6446. 857-6446. Guys, can you type in the PIN on the live for me, please? All right, let's keep going. LaShonda Harvey, it won't let me into the Kahoot. You know what, LaShonda, I'm sorry. If you guys can't get into the Kahoot, this Kahoot got flagged right before I started the Kahoot, and I did the thing. I forget what it's called, but I did the thing where you say, there's nothing wrong with the Kahoot I'm teaching. I don't know if it went through or not. I did like a petition. Try to get in. Let me know if you get in. 857-6446. All right, next question. If you can't get in, just participate on the live. Blank is a corticosteroid that's used in pregnancy, and I can't even read. Let me start over. Blank is a corticosteroid used in pregnant women at risk for preterm delivery. It promotes lung development. What do we talk about? Is it betamethasone? Is it nifedipine? Is it calcium gluconate? Or is it calcium chloride? Which medication is a corticosteroid that's used in pregnant women who are at risk for preterm delivery? This drug helps to promote lung development. What are we talking about? Very good. Betamethasone. What you expect to be ordered, guys, is either going to be betamethasone or dexamethasone. Okay, those two are the corticosteroids that we give to women who are at risk for preterm delivery. We want to make sure that the fetus's lungs is developed so they will actually survive outside of the womb. So we'll give this to anyone that's at risk that's less than 34 weeks pregnant. You need to know that. Nifedipine, of course, you guys know that is an antihypertensive agent. It ends in pene, so we know it's a calcium channel blocker. And the last two, calcium gluconate and calcium chloride, I talked about those already. Those are antidotes to what? Magnesium toxicity. Your patient's going through magnesium toxicity, you have to give them an antidote. Those are the two antidotes, one or the other. All right, select all that apply. Which of the following maternal side effects should you monitor for during corticosteroid therapy? So we just talked about this drug. You give it to the patient. What are you going to monitor for? Here are your options: hyperglycemia, hypotension, facial flushing, increased WBCs, insomnia, and xerostomia. Which of the following maternal side effects should you monitor for during corticosteroid therapy? Hyperglycemia, hypotension, facial flushing, increased WBCs, insomnia, xerostomia. What do you guys think? That's okay, Giselle. Keep going. This is interesting. Let's talk about it. Hyperglycemia, absolutely. Let me tell you something. When it comes to corticosteroids, if we don't know anything about corticosteroids, there are four things we know for sure, beyond a shadow of a doubt. It doesn't matter what kind of corticosteroid. If it's a corticosteroid, number one, hyperglycemia. Corticosteroids are very sugary. It can cause hyperglycemia. Number two, stomach ulcers. Corticosteroids are very hard on the stomach. That's why we never give it on an empty stomach. You'll mess around and give the patient an ulcer. God forbid it becomes a bleeding ulcer. Number three, what's the third thing we need to know about steroids? Infection. Yes, steroids can mask the signs and symptoms of infection. You have to watch your patient a lot closer. You got to watch the temperature. You got to watch the ESR. You got to watch the CRP. You got to watch the WBCs. Steroids can cause leukocytosis. You can see an elevation in WBCs. And the fourth thing you got to know about steroids is it can cause the bone to be porous, right? So we're going to be concerned about safety. Steroids will mess around and cause your patient to have, what's that condition when your bones are porous? Oh my gosh. Guys, what's that condition when your bones are porous? Osteoporosis, thank you. You'll mess around and have osteoporosis. We're concerned about safety. We're concerned about falls. If you don't know anything about steroids, know those four things about steroids that I just said to you. But anyway, I digress. So hyperglycemia, yes. Hypotension, no. If anything, steroids can possibly cause hypertension. It can cause the blood pressure to go up. So no on hypotension. Facial flushing, no. We see facial flushing more with drugs such as vasodilators. Increased WBCs, yes. Leukocytosis absolutely is a possible side effect. Insomnia, absolutely. Corticosteroids can cause what? CNS stimulation. Yeah. And xerostomia. What's xerostomia, guys, on the live? Can you tell me what xerostomia is? Very good. Dry mouth. No. Corticosteroid doesn't cause xerostomia. Drugs like anticholinergic agents or antihistamines, some antidepressants, they can cause xerostomia, but corticosteroids do not cause xerostomia. So yes, on the hyperglycemia, the increased WBCs, and the insomnia. Select all that apply. Immediate birth is indicated if any of the following complications happen. Select all that apply. Here are your options. Imminent or actual eclampsia, uncontrolled severe hypertension, pulmonary, it's supposed to be edema, I spelled that wrong, sorry. Pulmonary edema, placental abruption, evidence of non-reassuring fetal status, fetal demise. So select all that apply. In what condition would immediate birth be indicated? Mom's going to have to go into labor. That baby's got to come out. What situation? Here are your options. Imminent or actual eclampsia, uncontrolled severe hypertension, pulmonary edema, placental abruption, evidence of non-reassuring fetal status, fetal demise. Only 12 of you guys chose pulmonary edema. Let me ask you something. Are you ever supposed to have fluid in your lungs? Are you ever supposed to have swelling of your lungs? Absolutely not. If you can't breathe, nothing else matters. You're dead. Right? All of these are medical emergencies. All of these are indications for immediate labor. Immediately. Imminent or actual eclampsia. What does that mean? Mom goes into seizures. Look at the next one. Uncontrollable severe hypertension. Did I spell severe wrong? S-E. Oh, I said server. Sorry, guys. Uncontrollable severe hypertension. First of all, the word uncontrollable should have been a red flag to you. And if you didn't catch that, severe should have been a red flag to you. Come on now. That absolutely is a medical emergency. Next, pulmonary edema. If you cannot breathe, nothing else matters. Absolutely. Placental abruption. Patient has placental abruption. Immediately they're having a C-section. Immediate labor. We got to take care of that. Okay, that patient can bleed out. Evidence of non-reassuring. You have reassuring status and non-reassuring status. Non-reassuring status is bad. Immediate labor, and of course, fetal demise. That means that the fetus is no longer, I don't even know the politically correct term we're using these days, but you know what I mean. Viable. Is no longer viable. Okay, it's in the womb. If it stays in the womb, you want to know what happens to mom? She turns septic. All right, after an evacuation of the uterus, what is expected to be ordered to prevent hemorrhage? Here are your options. Oxytocin, a hemorrhagectomy, analgesics, or opioid narcotics. After an evacuation of the uterus, what is expected to be ordered to prevent hemorrhage? Very good. Most of you guys chose the correct answer. Oxytocin, oxytocin that causes muscle contraction, right? And so decrease the risk of hemorrhage. Guys, on the live, one of the options I made up. It's not a real word. It's not a real condition. It's not a real intervention. Which one did I make up? Can you tell me which one I made up? Not Pitocin. Pitocin's oxytocin. Yes, hemorrhagectomy. I made that up. It's not a real thing. Ectomy means removal of. Hemorrhage, removal of. So I just put that in there because I knew at least one person would see the word hemorrhage and say, oh, this must be the answer. Nope, gotcha. And the last two, analgesics, opioids. Analgesics help reduce pain, and opioid narcotics, those are a type of analgesic, so that's not the answer. So if after there's been evacuation of the uterus and you want to control the bleeding, you don't want the patient to bleed out, we expect oxytocin to be ordered. That causes uterus contractions, okay? The muscle will start to contract and decrease the risk of bleeding out. True or false? The action of terbutaline is to promote contractions and induce labor. Is this true or is this false? Terbutaline. Is terbutaline given to promote contractions and induce labor? Is it true or false? You guys are doing great on the live. Very good. False. It does the opposite, guys. This is a beta adrenergic agonist, and what it does is it stops preterm labor. It stops those contractions, okay? Two important things you guys have to know about this particular drug. It can cause maternal tachycardia and hyperglycemia, so you're going to be watching out for those, okay? Last question. Select all that apply. What are important side effects and adverse effects to know about terbutaline? So I'm asking about both side effects and adverse effects. Here are the options: tremors, jitteriness, tachycardia, chest pain, dyspnea, shortness of breath. While you're choosing your answers, let me make it clear there is a difference between side effect and adverse effect. Very often we use it interchangeably, but they are not the same thing. Side effect are things that may possibly happen. We warn the patient that it can happen. We're not going to change the med. We don't expect the doctor to change the med, the dosage, anything. But we warn them so they're not caught off guard. Adverse effect are things that can possibly happen that we warn them can happen, and we tell them if it happens to let us know right away. Why? Because we expect the healthcare provider, because it's so bad, we expect the healthcare provider to either change the drug, change the dosage, change something. That's how serious it is. Adverse effect is worse than side effect. Very good, all of them. All of them. With terbutaline, again, guys, it stops preterm labor contractions, but there are side effects and adverse effects you need to know. Let's talk about the side effects first. Tremors, jitteriness, tachycardia. And when I say tachycardia, I mean mild tachycardia. So your heart rate's supposed to be 60 to 100. Okay, it might cause your heart rate to go to 104, 105. Not life-threatening, right? If we're in the 110, 115, now we're in adverse effect area. Chest pain, adverse effect. Dyspnea, adverse effect. Shortness of breath, adverse effect. Anything that has to do with your lungs where you can't breathe. Can you live without not breathing? No. That's going to be an adverse effect. And guys, that is it for this video. Please let me know in the comment section what you thought about this video and what you'd like to see me cover next. And maybe you really don't like this Kahoot format. You still want me to talk about these subjects, but maybe you want me to do a lecture on it, or maybe you want me to do a Q&A. Let me know, sound off. I cannot respond to everyone, but guys, I do see your comments. I try to respond to as many people as you can, but there's literally thousands of you and just one of me. But I do see your comments, and I will try to accommodate as much as possible, okay? All right, let's see how you guys did. Third place. Leah, congratulations, Leah. Good job. Second place. Kenyan Angel, congratulations, Kenyan Angel. First place, drum roll. Stress student, congratulations, stress student. First place, runner-up, and Smith and C. Great job, guys. Great job. All right, let me turn this camera around. Let me stop the recording. You're welcome. Running into this life was God's way of telling me to study. Pretty cool, and thank you for your time. You're welcome, Tiara. Cher says, love the prayers pre-video as well. Oh, I'm so happy you enjoyed them. I'm so happy. You guys are so, so welcome. You're so, so welcome. Listen. Oh, Zaga Ziggy, IT Remeu. Oh, Mreme IT too. Listen, guys, you guys are the next wave. How do you make that drink? I wish I knew, but it's so good. I promise. Find you a Haitian and ask them to give you. It's called cremas. I need to YouTube how to make it. I have no idea how to make it, but it's so good. I promise you. But listen, guys, you are the next wave of the nurses that are coming through. So I'm telling you, what I'm doing for you, I want you to pass it on. You may not be an educator. That may not be your gift. Your gift may be somewhere else. But whatever it is, when you get that license, make sure you're a blessing to somebody. Don't just keep all the benefits of the license just for you and maybe your spouse and your children. No, pass it on. Bless other people with that. And you're going to see how your life is going to change. I promise you. Oh, Machiella says easy to make. Listen, I'm going to post this video on YouTube. It's going to be under my Kahoot playlist, and it's going to be under my maternity playlist. In the comment section, can you go ahead and give me the recipe? I'd appreciate it. I know how to make cremas. I'm so jealous. When is the next live? Tomorrow. The pediatrician I work with, she is on a cruise. She's living her best life right now, so I'm covering for her. So I'm going to be seeing my patients tomorrow morning. So I will not be available to do a Kahoot until the afternoon. So probably tomorrow evening. But I promise it looks similar to coquito. Yes, it's similar. It tastes a little bit the same. Not the same, but similar. What was I going to say to you guys? Yes. So tomorrow, most likely in the evening, I'm going to do another Kahoot. However, I'm going to be on YouTube because you guys act so jealous. This is so crazy. But I know if I do too many on YouTube, they're going to say, oh, you forgot about us. So I'm alternating. If I do a live on YouTube, the next live is going to be on TikTok, then YouTube, then TikTok. So tomorrow I'm going to do a live. It's going to be on TikTok. But again, I'm going to make a video letting you know, hey, I'm going to be live in 5 minutes. So you guys have a chance to go to TikTok. Make 2 of you. I wish I could. I wish I could. All right, guys. So I'm going to let you go so I can go ahead and post this video on my YouTube channel. Listen, if you're new to my channel, I don't believe in fluff. You know how some people just be talking about some things, but some of the things they talk about is important to them, but it's not important to NCLEX? That's not me. That's not me. If something's important to me, even if it's important to me, if it's not on NCLEX, I'm not going to talk about why, because guess what? I know you guys come on my channel because you want to learn, you want to pass your test. I believe in the meat and potatoes. So if it's coming out of my mouth, if I take the time to say something, I promise you, chances are high you're going to see it somewhere. Make sure you know it. Go back, watch the video, press pause so you can take notes, and make sure you research every single thing that I talk about, because on the Kahoot, I'll talk about the answer, but then I'll talk about the other options. The other options may be a question on your test, not my answer, but something else. Therefore, everything that I take the time to talk about, you need to know, okay? Giselle, I love the way you get us all together. That's the mama in me. I don't even know when I do it. You guys know I never watch my videos. When I make a video for you guys, I edit it, just, cut out the beginning end, and I post it. That's why when you watch my videos, I might be talking about something and I realize I made a mistake. And I'll be like, guys, what I said, that was foolishness. This is what I meant. Want to know why it stays in there? I don't edit it out. I have an editor, and I tell my editor to keep that in. Why? Number one, you need to know I'm human. I'm human just like you guys are. And you have to learn from mistakes, because if I made a mistake, you might make the mistake too. I don't like watching myself. I don't like hearing my voice. If I ever had to watch myself before I posted something, you guys would never get content. You guys would never get content, because listen to me. Look at this lisp. I can't even speak. I sound like a little kid. You think I want to hear that? Absolutely not. So I don't even know when I do the most. I just do the most and I post it. You remind me so much of my Haitian clinical instructor. I love her so much. Oh, that's funny. I love it. All right, guys, I'm going to go post this on YouTube for you. Give me about 20 minutes. It's going to be posted. Thank you so much for your participation. Everybody that engaged, everybody that liked this live. I don't know how YouTube works. I'm not on TikTok. You double tap on the screen and it gives the like. Oh, no. On YouTube, it's a thumbs up. Okay. Everyone that gave me a thumbs up, thank you. I appreciate it. I appreciate the engagement. I'm going to get going so I can post this for you guys, okay? Have a great night. Now I got to figure out, how do I turn off the live on YouTube? Where do I go to turn off the live? Let me try this. Start a poll, start Q&A. No, that's not it. Share with your audience. No. How do I turn off the live? You guys know I'm old. Huh. Are you sure you want to stop streaming? Yes. Okay, bye, guys.